Woo! Okay, I'm Kelci Lange. I did my internship at an outpatient orthopedic clinic in Saginaw, Mission. It's called St. Mary's Spine and Rehab. I chose this patient. She has acute on-chronic low back pain following significant weight loss. And I chose this patient because she has really interesting surgical history, medical history, and I think something I saw a lot was kind of an acute exacerbation of chronic low back pain that had been happening for a long time. So I just wanted to present this and get your ideas on what you thought about what I did for my patient and just open up a conversation about other things that we could have done. So as far as her history, she came to me with a medical diagnosis of midline low back pain without sciatica and of unspecified chronicity. She's a 49-year-old female with a 15-year history of recurrent low back pain with no specific onset. Her occupation, she worked for Habitat for Humanity. Essentially, it was like a 75% desk job, 25% going to houses, having to move boxes, things of that nature. She came to me February 7th, but her date of exacerbation was sometime around the end of January. And again, no specific onset, just really increased her pain one day, went to her doctor, and now she's fine. So as far as her surgical history, in August of 2015, she had a vertical sleeve gastrectomy, which is a laparoscopic surgery. They put a sleeve on the stomach, and they make it about the size of a banana. She ended up losing 125 pounds from that surgery at about the time she saw me. She was about the same, a little bit taller, kind of same size and stature as I was, so an otherwise healthy female, if you will. And she had no low back pain since the surgery, so this was really the first time she's had back pain with this kind of new body. She's also, she has had a transobturator sling put in 2014. So she had physical therapy for stress urinary incontinence. She was unsatisfied with the results. It didn't quite really fix her problem. It actually did help with her low back pain a little bit, but she went ahead and had the surgery, and at this time she's been, her incontinence has been fine. And this kind of opened the opportunity for me to ask about any urinary retention or fecal incontinence to rule out some red flags. Her medical history, so some more kind of interesting things. She has had lupus. It's in remission right now. She hasn't had a flare-up in quite a while. She also has the diagnosis of fibromyalgia. And she has Sjogren's and Raynaud's, which those are two things that are typically associated with an autoimmune disease. Sjogren's is actually just like a dry mouth, dry eye kind of thing. You just have a difficulty producing mucus. So she really just kept like a water bottle with her. It didn't really affect any treatment. And as for Raynaud's, I just wanted to be careful applying ice packs, things like that, so she shouldn't have a negative impact on her cold, achy fingers. For diagnostic testing, she didn't have any for this specific event, but she stated that she had previously had a bulging disc at L4 and 5. I'm not unsure at what time that exactly was. So some more history and medications. She is on an antidepressant, and she's on a medication to help her hypoactive thyroid. And just recently, her doctor put her on Flexeril and Norco, so just to help with that muscle kind of pulling or spasm, as well as pain over the past week. So talking to her, we found out she had some functional limitations, especially with transitional movements. So rising from a chair, she really had a lot of pain getting in and out of her car. And she had difficulty just moving around, getting in and out of bed. She could stand for no longer than 10 minutes. And she had a lot of difficulty bending over, like to tie her shoes or to pick things up from the floor. Her sleep was also really disrupted. She was waking about every hour from the low back pain. And she was avoiding walking and stairs whenever she could. As for her pain, she reported it as achy and tight across the entire low back, and it occasionally radiated into both buttocks. Pain was as low as 0 if she was resting comfortably or on pain medication, and it was typically around a 2 to 3 out of 10 while she's performing like her daily activities of her job. When it first occurred, she said it was 9 out of 10, so she went to her doctor. It was really examination findings. So this isn't an actual picture of her, but it really demonstrates what her posture looks like. So that rounded shoulder, forward head, anteriorly tilted pelvis. Just looks like she's hanging on her bones and her ligaments. As far as her gait, she had kind of this increased truncal shift to the left, so it almost looked like a compensated Trendelenburg type of pattern. And she was just really loosey-goosey, lots of posterior translation of the pelvis as well. So one thing we did to sort of assess some SI joint in a dynamic sense, we asked her to walk with her feet. The duck feet internally rotated, so we're thinking we're distracting her on the SI joint. And then with the feet externally rotated, so we're thinking we're compressing the SI joint. And she did have some increased pain walking with the feet externally rotated, so that compression. As far as movement assessment, I try to do a sneaky little assessment of just how they sit to stand from, getting out of their chair to go back to the initial evaluation room, as well as how they get on and off the plinth. So she chose to get up from the plinth with this sit-up strategy. So we educated her on doing a log roll technique while her pain was so increased. As well as her sit to stand, she had to use her hands, and she kind of favored this one side to try to stand up from the chair. Examination findings, her lumbar assessment, she actually had full flexion, which kind of surprised me. Her lumbar extension was extremely limited and painful. She also had a lot of pain with left side bending, and it was decreased. Everything else pretty much looked okay, checked out the hips, range of motion there was fine. Assessed hamstring length, not a crazy amount of limitation, but it was painful, so I just kept that in the back of my mind. For joint assessment, I assessed her pelvis. She presented with a right anterior, left posterior rotation. She had a sacral dysfunction. The sacrum appeared to be kind of side bent to the right. For her lumbar spine, she was just generally hypermobile, except when I was trying to assess left rotation. And it was mostly limited by muscle guarding, just increased paraspinals in that area. For strength, she had a lot of weakness around the hips. Hip flexion, she also had increased pain, which might explain why she had such difficulty getting in and out of her car. And her hip extensors and abductors were extremely weak when I was assessing them. I also assessed her lower abdominals. We taught her how to do a Kegel and a transverse abdominis contraction at this time in the hook lying position. And she really had a difficult time isolating that for more than a few seconds. For special testing, so I did a couple of things. I wasn't really thinking like a disc problem, but I wanted to rule that out since she had had a history. So I did a slump test. It was negative. I did a straight leg raise. It was equivocal on the right. She did have some pain, but it was kind of right in the spot in the low back where she's had it. It didn't really radiate down the leg. So I also wanted to look at the SI joint. I'm thinking it's pretty irritated at this point. So I did a compression, which actually relieved her symptoms. So I wasn't sure if I should call that a positive or a negative, so I also put that as equivocal. And then the SI distraction didn't really change anything. She was still kind of in the amount of pain that she had when she came in. So the prone hip extension, that's assessing the muscular sequencing of the glutes, hamstrings, and the multifidus. So she was on her belly. I asked her to lift one leg in the air. And what I'm expecting to see is a nice strong contraction from the glute, followed by the hamstring, followed by the multifidus or the paraspinals, because they're going to resist that rotation of the spine. So what I saw was immediate firing of the hamstring. So that's telling me there's some neuromuscular coordination that we're missing. So I also asked her to just, if she was able to isolate a glute contraction at all. And she couldn't. She could only squeeze both together at the same time. So with the prone hip extension, we're seeing that decreased neuromuscular coordination. So we're losing some stability around the spine there. Like there are three ways the spine is stabilized. So we have the actual bones and the ligaments themselves, dynamic control from the muscles, and then the neuromuscular control. So we can see from this test, we lost some neuromuscular control. From the strength assessment, we've definitely lost some dynamic stability. So basically, she's relying a lot on just her bones and her ligaments to keep her upright. For outcome measures, I found a really cool article that evaluated 75 different outcome measures for the low back. And it said that all three of these measures were valid and reasonable to use for low back pain. As for her numeric pain rating scale, like I said, it ranged from kind of a 3 on average up to a 9 out of 10. To assess her psychosocial aspect, we used the Beck Depression Index, which she scored a 0, which meant she wasn't exhibiting any signs of depression. As for the Roland-Morris Disability Index, that one is also suggested to use by the low back pain clinical guidelines. And she scored high on this one, 19 out of 24, indicating that subjectively she believes she's pretty highly disabled. She's unable to do a lot of functional activities because of her back pain. So patient education. We provided her with a patient handbook that talked a lot about chronic pain, the chronic pain cycle, and chronic pain thoughts like fear avoidance behavior. It also has a page in there that talks about icing in order to decrease pain in the short term and to decrease swelling and inflammation. We talked about sleeping positions, like putting a pillow between the legs while she's sleeping at night so that she can sleep hopefully a little bit longer. There are a couple pages in there about sitting and standing postures and how she should set up her workstation at her Habitat for Humanity job. And then there are a couple pages in there about bending and lifting techniques to help protect the spine. So like I said, we taught her how to do a log roll that day. And we also issued her an SI belt. So since we had relieved symptoms with compression in that test, we thought maybe an SI belt would be a good idea. So we put it on, we had her walk. She said she felt a little bit better. I also have a couple of resources that talk about using SI belts. One of them says that it can help reduce pain and increase physical function. And that study, they wore the belt for 3 hours a day for 6 weeks. I'm not thrilled about that. I don't really want my patient to have to wear it for 6 weeks, 3 hours a day. I'd rather her use it in the short term so that she can complete her daily activities, work at her job, while we build that dynamic stability that's not there yet. I also found another study that just assessed it in basically how the pelvis and sacrum are affected in a computer. So does it translate to humans? Maybe, maybe not, but it just looked at the ligaments and how they were slackened, and it noticed that especially the sacrotuberous, sacrospinous, and iliolumbar ligaments, when the belt was applied, were relieved and just put on a little extra slack. So essentially what that's telling me is with sacrum, we have our force closure and our form closure. So with our force closure, it's that dynamic control. So we're adding a little bit of extra force closure using that belt. Okay, so let's evaluate everything that I just found. As far as her impairments, she has decreased strength in the hips and in the core. We've got some lumbopelvic dysfunctions, decreased postural awareness, hypermobility in the lumbar spine. We've got some soft tissue restrictions, a little bit in those paraspinals and the hamstring, some gait deviations, and of course pain. So for my diagnosis, using the clinical guidelines for low back pain, I placed this patient in acute low back pain with movement coordination impairments. So to solidify that hypothesis, the guidelines included these three things. So my patient does have an acute exacerbation of recurrent pain. She did have pain at the initial and mid ranges, thinking like extension and that side bending. And she has movement coordination impairments in the lumbopelvic region, especially in flexion and extension. So my patient did not have any issues with flexion, but extension was definitely an issue for her. So goals. My patient and I kind of discussed what she wanted to do. She wasn't thinking function. She just kept talking about how weak she felt and how bad she thought her posture was. So we did talk about improving her hip strength and improving her postural awareness, but we linked them with some functional things, like strength for transitional movements to be able to do her sit to stands, rolling in bed, abdominal strength to perform or to increase her ability, spin, lift things up, tie her shoes, and then improving her postural awareness so that she can stand and like cook dinner. So prognosis. We had planned on 2 times a week for 4 to 6 weeks. She had told us at our initial evaluation she was going to be off for a week in early March, so we thought we would maybe kind of have to play with an extra week or so. We found out later that she had a conference in late March. She also was sick for quite a bit during our time. So we ended up actually seeing her for about 10 weeks, and I'll kind of explain to you why it had to be that long. And so it just kind of, life got in the way, to make it pretty simple. So a couple prognostic indicators. Positively, she was extremely motivated. She believes in PT. She was excited to be here. She was ready to get stronger and improve her posture. Negatively, she did exhibit some of those fear avoidance behaviors. So she was avoiding stairs and walking. And I haven't talked about this yet, but she does have some familial stress, which I didn't find out until our very first visit. She's kind of caring for her partner, and she had a death in the family later on. So We'll get into that a little bit later. So my plan of care. So using evidence-based practice and thinking of my patient's preferences, she was really focused on posture and strength, so I've got that in there. As far as my clinical experience, I had been there for about 4 weeks and had seen some pretty good results with some of the things that we had chosen here. And as far as research goes, I read an article about postural awareness, especially with sitting posture. They examined different postural muscles in different sitting positions. And the one significant thing they found was in a slumped posture, the internal oblique and the transverse abdominis are the first to basically turn off, and that's within 20 minutes of sitting. So that really motivated me to want to work on her hip and core strength and work on her sitting posture. So for lumbopelvic stability activities, I looked up some research, and I found at least a couple here, talked about using hip and core strength in conjunction with each other rather than just using like lumbar stability or core strength alone. So again, just a couple of other findings. I wanted to increase that hamstring length, especially on the right side. And then I could perform some manual pelvis or sacral mobilizations to fix those dysfunctions, as well as lumbar mobilizations, mainly just for pain, like grade 1, grade 2. So here's everything summed up in our beautiful ICF model. And at this time, I'll go ahead and take some questions if you guys have any so far. Nothing? Guys. Okay. So I'll continue on. As for interventions, I kind of split this up into 2 different phases because we had, you can see from the 7th to the 20th, quite a little gap there. So for the first month, I saw her 4 times because she was ill. And her garage door was frozen shut. Did I tell you I was in Michigan? So we focused mainly in the first 4 weeks on some just muscle activation, getting things to fire in the hips and in the core, decreasing that back pain, using ice whenever we thought it was necessary, and then just talking about postural awareness and educating the patient. So the second half, we just kind of bumped everything up a bit, challenging the hips and core in functional positions, incorporating multi-plane, multi-component movements, and continuing to address postural awareness and education whenever necessary. So for our warm-up, we did some treadmill walking, and we did this forward, backward, and in the side, like side to side, to just start working in different planes of motion. We also did some decompression, so that's the picture there. It's basically just reversing that forward head posture, kind of stretching out the chest, adding a little decompression to the spine. She really loved this at the beginning. It really helped kind of just relax her and reduce that pain. And then we also added a hamstring stretch. So for our home exercise progression, what we kind of did in the clinic was we introduced a few exercises at a time, made sure they looked pretty good, sent them home with her. So we just kind of kept that going on. So basically we kept no secrets. She pretty much had pictures of every single thing that we did in the clinic. So if she were ever to have another exacerbation, technically she could pretty much manage it on her own. So we started here with just some gentle kind of supine postural things, getting the back of the body to turn on. So a head press, scap retract, an elbow press, and then a leg press. We also introduced transverse abdominis progression. So we introduced this in the initial eval, but we always review it in the first treatment. We do a lot of palpating and teaching the patient how to palpate so that they know that they're doing the contraction right and they can feel it. So we progress that to isolation, to marching, to single knee fallout, and then adding various resistance bands. So we try to get to function as best we can, get them up off the mat. Oh, with that, we also do a sideline clamshell, so for technique progression. So after that, we try to get them as functional as possible, getting on the edge of the mat, doing a hip hinge, learning how to do a sit to stand properly instead of that kind of weird push to the side technique she was doing. She had a lot of difficulty doing a sit to stand from a standard height, so we introduced some mini squats first and just practiced that motion, and then did sit to stands from varying heights. So once we get our sit to stand down, we've got her standing, we do some side stepping, some zigzag walking, and then we introduce resisted walking. We have a pulley machine at our clinic. You can put a belt and you can walk probably 10 or 12 feet forward, and then it's walking backwards. So it's that concentric control, eccentric control in various planes, so side walking, forward, backward. And then finally, I try to give my patients something to do in the car. I knew she was doing a lot of traveling and a lot of driving, so basically told her to practice her TRA and her Kegel isolation, and to practice glute sets. So squeezing the right butt cheek, squeezing the left butt cheek, and then squeezing both together. And I actually found an article that reviewed like 25 different glute med, glute max exercises, and they found that doing just a plain old glute set can recruit like 90% of a max contraction of the glute. So that's pretty good. So here we are at visit 5. So it's been 4 weeks. We're doing our progress note. So I just kind of split this up into improvements and basically things we want to continue to improve or limitations. She reports her pain on average as 0 out of 10, which that's great to me, but she's still having difficulty with transitional movements. So is her pain 0 out of 10 really? I don't know. Maybe she was trying to make me feel good. She was no longer afraid to walk, but she said she was still just kind of avoiding stairs. As far as postural awareness, she reported she was correcting her posture, but she could still feel herself just kind of rolling over. And at this point, I did assess some like scapular strength, so basically low trap, mid trap, and rhomboids, and they were just pretty globally weak. And if I could go back on that same day, I would have assessed her thoracic spine just to see how it was also moving, but I didn't. So standing at this point was in functional limits. She had no problems. But she was still waking a couple times a night from her pain. So at this point, we had a conversation. She's at 0 out of 10 pain. Functionally, she's getting around pretty well. I just kind of asked her what she wanted to do. And she said she wanted to continue working on her strength and her posture. She wasn't where she wanted to be yet. So, and I found some physical examination findings that supported that as well. She still had a lot of weakness in that left abductor, and her prone hip extension was still delayed. So we were missing some of that neuromuscular control. We still hadn't found that yet. So for her second kind of main progression, this was what we had been working on before her next. She had a conference at the end of March. So we discontinued some of her lower level stuff. She accomplished all the postural activities. She'd really done well with some TRA things. And we added some activities to work up the chain a little bit. So we added some rows and presses, really focusing on good posture with those. We added some single leg stance activities, which we introduced them and her balance was not very good. So we had to actually regress that to tandem stance for a couple of visits. And then we were able to do some single leg stuff. Like that over there is basically a TheraBand external perturbation exercise standing on one foot. We also added planks. This was another exercise that article that reviewed all those glute med, glute max activities. They said planks were the #1 way to really get the glute med and the glute max to fire, especially if you can add like a front plank, a hip extension, a side plank, some hip abduction. And then we added just some more complex movements, like a crossover step up. It's like a mini squat, crossing over onto a step, and then stepping up, activating the posterior chain, just kind of moving around a lot. And then we continued some resisted walking, just upping the weight. So now we're at our discharge, which is now April 18th, which was like my second to last day there. She had basically, after her conference, her partner experienced a lot of heart issues and wasn't able, so she had to take her to the hospital frequently. She had a death in the family. Pretty much we had just kind of missed our communication to get her back in there, but she was nice enough to come into the clinic and at least let me take her discharge measurements and progress her home exercise program one last time. So she had reported 95 to 100% improvement. She said she had no functional limitations, but essentially she was just overwhelmed with family and work, so she was pretty disappointed that she wasn't able to be as committed as she wanted to be. For her strength, she made some good gains. I wasn't disappointed. I wish, of course, they could have got her up to a 4+, and she still kind of had some lagging in that hip extension, actually there on the left this time. But her lower abdominals really improved. As far as hamstring length, it felt fine now, it was normal. And she still had a little bit of that delay on the left side, but it was promising to me that on the right, the sequencing was a little bit So as far as pelvis and sacrum, I didn't notice any dysfunctions. She had 0 out of 10 pain. Her BDI remained 0, and the Roland Morris was just now a 1 out of 24, which the MDC and MCID are around 5, so we built that one. She said she was mainly just having difficulty lifting like heavy things. So limitations. We kind of had choppy, infrequent visits. I didn't love that, but it worked. It helped. She performed her program, and it worked well for her. As far as just like a standing static hamstring stretch, I felt like I got lazy with that one. I could have done something more like a PNF because I don't think it was hamstring shortening. I think it was more of a neuromuscular kind of reaction. And I wish I would have performed the entire SIJ cluster or sacroiliactoid cluster just to solidify my hypothesis that she had some SI joint irritation and dysfunction going on as well. For a psychosocial aspect, she had a lot going on at the end of treatment, and really the only thing I did for her was recommend an app called Calm, and it basically just has different tiles about decreasing stress, increasing happiness, things like that. You pick what's wrong with you, and just provides you with some like breathing and relaxation techniques. So I want to open it up to you guys. What do you think? What do you think I could have done differently? What would you have added? What did you like about what I did? Chad.
Did you do any pain signs or anything?
I didn't. Her pain had decreased a lot, so I wasn't really, and she wasn't pain focused, which was shocking. Like I saw a lot of people that were pain focused, but it didn't really do that with her. She mainly was just focused on, she felt weak and she didn't like her posture, and I didn't have to do much of that.
I was curious what you did with the SIJ belt. You said you were hoping to not
Yeah.
have to use that as much.
So luckily with her, I asked her about it. She loved it. And as we progressed, basically she's like, I don't really wear the belt anymore. Am I supposed to? And I was like, yes, perfect. And she's like, well, I think would it be okay if I wore it while I'm like bending and lifting and doing heavy things? And I'm like, yes, that's fine. If you feel uncomfortable, if that adds at least that little bit of safety for you, I'm okay with that. So yeah, she did really well. She kind of discontinued the belt use herself. So she really self-managed. I was just there to give her the tools.
What would you think her comorbidities and her illness, legs, her overall chronicity problem?
Yeah, so she had a lot of back pain before, and at one point I remember her saying to me, this back pain was worse than when I was heavy. And so I thought that was interesting that she was kind of comparing the two things, because honestly, in my eyes, she's a whole new being, essentially. So I think it played a lot. I think it scared her because she hadn't had back pain in a year and a half. So, and she had tried to do everything right, and she still had it. So yeah, I think she was scared, but she got better, and hopefully we can kind of keep this from becoming a recurrent thing.
Do you think there are any issues with the perception of body image that may have their role in the current episode of care that you were involved in going down the road? And just the simple perspective that her body is completely different.
Yeah.
Perception of that.
Mm-hmm. That could be true. I didn't notice any sort of like insecurities or her being kind of unaware of her body. With her postural awareness, she mainly was just like, I know I'm slouched over. I know I'm rolled over. I just want to fix that. Like, I just want to sit up. I know when I sit at my desk like this, it hurts. I just want to fix that. So I wouldn't say this patient had a lot of kind of body disfigurement. I didn't really notice that with her. So could it have played a factor? Absolutely. Was it kind of apparent to me? Not really. Oh, I forgot to repeat the questions. Fail. Anyone else? Dr. Smith.
Guilty. You talked some about the SI, because it also seems similar to the discussion we had a little bit ago. And you talked about using the belt. My understanding was that was kind of change force. Did you check?
We did a sort of test retest in the initial evaluation. So we we did that external rotation walk. It was irritating. We applied the SI belt. We had her walk in various positions, and it felt better. So that was kind of our confirmation, hopefully, that it was.
Right. I mean, any special tests looking at abortion form closure?
No,
Okay.
can't say that I did.
So, and I noticed that you had the SI posterior rotated, inter-rotated under joint assessment.
Mhm.
Did you test for mobility?
I learned how to do that at that clinic, but I had not learned how to do it at that time. She taught me a lot of like pelvic rotation and translation up and down. So I'm thankful that she taught me that there, but I did not know it.
I encourage you to go look at the literature.
Uh-huh.
There's some discussion that actually we're dealing with bones, men, and not SI.
Okay.
So,
Okay, great.
but nonetheless, you address a lot of different areas.
Yes.
What would you say was her primary impairment?
I believe her primary impairment was definitely strength or weakness.
Let's go more specifically.
She was missing. Are you gonna make me pick between hip and core?
Wait, what?
Between the hip and the core.
I just want to be more specific. I heard some specificity that didn't really match up. So I wanna be
Lumbopelvic strength. So I think muscles of the hips and around the core. So inner core as well as glutes.
What I would like to hear is, think about, again, it's instability, like a check and change, so what's the work at the moment? So at one point I heard you say you wanted to work on abdominal strength
Yes.
to help bending. If we work on abdominal strength, what bending would that help us with? Forward bending or backward bending?
Backward bending.
Yes, I think you're not.
So posterior core multifidus paraspinal strength.
I don't know, that's what it sounds like,
Yes.
right?
I can understand how my wording makes that
Right,
sound.
so I don't think it's a lot of time working on abdominal, people say, why do we do that?
Mhm.
So, I think that's where I'm.
I think I would have preferred to say like inner core, like multifidus, TRA, pelvic floor kind of strength, rather than like global abdominal strength.
And then I'm encouraging related to a particular force, a particular function.
Okay.
So what was your asterisk sign?
My test retest.
I mean, it changed, no doubt, I hope so. What would, give me an example of what it might have been.
I would say just heard that back pain that was kind of radiating to her buttock.
I think we need to break this. Tell me people are. Thank you.
Thanks.